You know how we operate here. A train comes and leaves the station on time, and we arrive on time. So with that, let's start with our roll call, please.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll, Senator Elkins, Senator Funky Fromeyer, Senator Nemes,
Present.
Senator Tishner, Senator Wise, Vice Chair Douglas,
Present.
Chairman Meredith.
Present. We're going to be hearing Senate Bill 27 this morning, and this is my bill, but I will not be testifying. What we're going to do today is allow folks to speak both pro and con on this, and I'm devoting 20 minutes to each group, and I would respectfully ask that you stay within those guidelines. If you do it less than 20 minutes, you'll forever be in my debt. If you go over 20 minutes, you'll be banished to the gates of hell, and you wouldn't want that and become persona non grata. And to help everybody to keep on track, got this very sophisticated system we're using here. I'll hold up a sign when you got 5 minutes left, and hold up another when you got 1 minute left, just to make sure that we're all staying on track here. With that, speaking in favor of this bill, I'd ask those folks that would come forward. And just for the committee's information, this is just a hearing today. Hopefully we'll take action on this bill next week, but to that end, that's why I'm not testifying today on behalf of it, just allowing folks to have their say. But folks, appreciate you being here this morning. If you would, please identify yourself for the record and proceed. Green light's got to be on your microphone. Make sure that's...
Good morning. My name is Philip Allmeter. Thank you for allowing me to speak to this important piece of legislation. I serve as the chair of the Pharmacy Committee for the Kentucky Hospital Association, who I'm speaking on behalf of. I also serve as the Chief Pharmacy Officer for the University of Kentucky Healthcare. 29 drug companies have significantly cut access to 340B access to hospitals through their partnerships with community and specialty pharmacies. They are doing this to avoid some of the largest discounts on some of the most costly medications. Drug manufacturers' refusal to offer 340B pricing dramatically restricts the benefit of the 340B program, negatively impacting the ability for covered entities to provide care to those in most need. These restrictions harm patients. They strip hospitals and other 340B providers still recovering from the pandemic, facing labor shortages and grappling with inflation. A study done by 340B Health of data from HRSA found that as of June of last year, when there were 21 of the 29 manufacturers participating in this activity, that the amount of annual savings at stake for safety net entities was estimated to be $8.4 billion a year. Showing these activities are stripping hospitals of critical savings for patient care. The Kentucky Hospital Association also did their own study in December last year and found that this impact for Kentucky hospitals has been $122 million a year. Of note, $60 million of that is rural hospitals. And it should be noted that this study did not include federal grantees such as FQHCs. States are leading the way in safeguarding 340B for hospitals. In addition to Kentucky, 9 states have introduced contract pharmacy legislation so far in the past year: Massachusetts, Michigan, Missouri, Virginia, Florida, Nebraska, Iowa, Oklahoma, and West Virginia. Arkansas passed the first law prohibiting manufacturers from imposing these restrictions in 2021. And last year, Louisiana did the same. I believe it's important that we distinguish what Senate Bill 27 does and what it does not do. Senate Bill 27 protects Kentucky healthcare providers against manufacturers using discriminatory pricing practices. For example, a manufacturer cannot give an Arkansas provider and its contract pharmacies a 340B price, but then refuse to offer the Kentucky provider the same 340B price for the same drug. Stated simply, if a 340B price is fair for an Arkansas provider, it's fair for a Kentucky provider. Senate Bill 27 prohibits out-of-state manufacturers from cost shifting. their higher drug prices to Kentucky providers, while giving providers in other states lower prices. Senate Bill 27 offers these state protections against discriminatory conduct with the existing context and parameters of the federal 340B program. In short, the cost of inaction will fall on Kentucky providers and patients. What Senate Bill 27 does not do is it does not alter the 340B program, nor could it. That program has been around since 1992. It's a federal program, and as such, providers, patients, and legislators in Kentucky, we can really only operate within that program as dictated by the federal government. I'd like to share 3 examples of how the 340B program has directly impacted patient care at my employer, UK Healthcare. UK Healthcare lacks a home infusion service. So we've developed a 340B contract pharmacy relationship with a partner, Option Care. Through this relationship, we are able to serve our patients' needs for patients that UK identifies as having financial difficulties. We communicate these to the contract pharmacy partner, and we are able to cover the cost of these infusion medications. And it's beneficial that it's at the 340B price, so it's not as impactful. 340B savings are generated to allow us not only care for the uninsured, offering uncompensated care, but also the insured. For example, patients are encountering financial toxicities. There are some medications that we dispense that the copayment on a monthly basis is $4,500. $4,500. Fortunately, when we encounter these obstacles, we have hardwired a program to assess financial needs and lower copays this high to as low as $10 or even $0. The ability to lower these out-of-pocket costs is directly related to the 340B program. Finally, in the U.S., hepatitis C causes more deaths than all of the other 60 reported communicable diseases combined, and it disproportionately affects Appalachia. UK has invested in a robust Hep C program, and we are now screening for hepatitis C in the emergency department and primary care. And upon positive screenings, we are immediately treating with our UK specialty pharmacy. UK invested $1.3 million in infrastructure, in pharmacists, analysts, coordinators, and providers to make this work. The national treatment rate for Hep C positive patients across the country is 10%. With our program, we have brought our treatment rate to 62%, gaining national attention. None of this program would be possible without reinvesting 340B savings into personnel and infrastructure to make that happen. Thank you. I will now let the next speaker talk.
Good morning. My name is Ashley Harrington. I'm the CEO at Owensboro Health Twin Lakes Medical Center. We are a 75-bed, not-for-profit rural community provider in Litchfield, Kentucky, which is Grayson County, approximate population of 26,000 people. We also serve 6 counties that surround us. 3 of these counties have critical access hospitals, and 2 of the other counties do not have a hospital within the county. We serve a financially challenged population. Approximately 70 to 75% of our patients are Medicare, Medicaid patients, or charity care. We participated in the 340B program for a number of years, and it's allowed us to increase the access of care that we're able to provide in these communities. Specifically, when you talk about infusion and high-dollar chemo drugs, we're able to provide these drugs because of 340B discount pricing. Without the 340B program, a lot of these patients would be forced to travel long distances to be able to receive these services. And in many cases, that would be very difficult for our patient population. We're also able to use the 340B discount savings to be able to invest back into our communities that we serve. A recent example of this is in May of 2023, we were able to open a new 12-bed inpatient geriatric psychiatric facility within our hospital. As you know, this is a much-needed service for the vulnerable population, the elderly population, and mental health issues that they are challenged with. This has been we have many wonderful examples from patients. So far, since May of 23, we have served about 100 patients in over 15 counties. We're the only inpatient geriatric psychiatric facility within our region. One of the wonderful recent examples that we heard from a patient and their family was they were unable to take care of their patient at home. And once they came and stayed in our unit for a short stay, they were able to go back home and live with their family and stay with their family. We are not in a unique situation at our hospital. We are like most other rural community hospitals in the state who participate in 340B. We utilize the program to be able to increase access to the most vulnerable Kentuckians that need care close to home. Thank you.
Good morning. My name's Don Lloyd. I'm the CEO of St. Clair Healthcare, based in Moorhead, Kentucky. We are a safety net provider. We have been for 60 years. 80% of our patients are either elderly, low income, or disabled. A total of 81% of our total revenues are generated by governmental payers of some kind. We experience about 1.25 million patient encounters a year in our facilities or in our services. We operate in 11 rural communities in northeastern Kentucky. I thank you for the opportunity, Mr. Chairman and Senators, to discuss the impact of the 340B program and its impact on those that we are fortunate to serve in 11 counties. I also appreciate your consideration of Senate Bill 27, as this bill will provide substantial benefits to the marginalized and the disenfranchised populations of Kentuckians we are so fortunate to serve. I'll not repeat the important benefits of this program as described by my colleagues testifying this morning. However, I would like to inform you of how beneficial this program is to the patients we do serve in Eastern Kentucky. My first example is the cost savings generated by the 340B program supports a pharmacist-run chronic care clinic in Moorhead. This clinic supports the needs of very complex patients with very costly chronic conditions, many of which are on high-cost drugs for their therapies. Because of the 340B program structure of the past, we could financially afford to offer more high-cost, efficacious drugs at affordable costs to provide the most effective therapies, monitor the patient's chronic conditions, prevent hospitalizations, decrease emergency room visits, and as this clinic targeted those who are most vulnerable clinically and economically. Today, this clinic serves over 660 individuals from the entire 11-county region we serve. Without 340B support, clinics serving this clinically fragile population would cease to exist. A second example is our work with patients in active addiction recovery. And another way that we do support the needs of vulnerable patients with the 340B program, cost savings. St. Clair is providing medications, laboratory services, hospital services, chronic disease management, telepharmacy services, medical homes for all individuals in addiction recovery with primary care providers, access to specialty care including gastroenterology, second chance employment, and higher education scholarships in the amount of $500,000 dedicated to second chance individuals. All of these services are provided through the cost savings of the 340B program. They are not government funded. These services are funded by St. Clair, and we're helping these individuals reclaim their health and dignity once again. Our services are designed to restore psychological and physiological health and with sustainability. Based upon St. Clair's current data, approximately 43% of the total individuals we serve through this program have some form of hepatitis, A, B, or C. We serve these patients with complex high-risk drugs in a clinic modeled after the University of Kentucky's hepatitis clinic. Our non-340B drug cost from the pharmaceutical manufacturers to St. Clair for many of these treatments can exceed $24,000 a treatment. I repeat, these are St. Clair's drug cost when not covered under 340B, not the patient's costs. St. Clair Healthcare's 340B savings are going directly back into our local communities to help lead these patients to a better life, a healthier life, a more productive life, and a better Kentucky. And last, there's another benefit to 340B. Another challenge that we face at St. Clair is that the pharmaceutical manufacturers are blocking participation in the program of the small, independent, rural contract pharmacies throughout eastern Kentucky. These local, isolated, independent pharmacies are prevented from participation and unable to pass along 340B savings to their patients because of the practices of these pharmaceutical manufacturers. And one just need to look at the current statistics of private independent pharmacy closures throughout the Commonwealth. This has a detrimental impact on patients who have limited access to care and is also economically hurting our small, rural, remote, and economically challenged communities. Independent, locally owned pharmacies in locations like Sandy Hook, Frenchburg, West Liberty, are now often prevented from participating in the 340B program given the conduct and practices of the manufacturers. The pharmaceutical company guidelines are often arbitrary and change frequently, sometimes from month to month. During the first 6 months of this fiscal year at St. Clair Healthcare, changes to what qualifies as savings by the pharmaceutical manufacturers have added a $3.6 million of cost back to our rural health system. That's $3.6 million in 6 months. These practices harm the underserved, the remote, rural communities, and we're struggling to serve. We are greatly challenged as a rural health system to get these patients the highest quality of care possible because of the affordability of drugs needed for treatment. The 340B program used to allow us and other small independent retail pharmacies to collaborate and provide our patients in their communities with the best guideline-recommended therapies at prices that many low-income patients could afford. We simply cannot ration care because of one's socioeconomic status. In this regard, I plead with you to support SB 27 for the benefit of our patients and for those trying to use the program as it is intended, not to benefit the pharmaceutical companies who are exploiting the purpose of the program for their own profit, and not using the program for the improved health of Kentuckians. Senators, I thank you kindly for the opportunity to speak with you this morning, and I'll be happy to answer any questions that you may have in this regard.
Wes, do you wish to speak?
Sure. Good morning. I'm Wes Butler. I'm an attorney in private practice. I represent a lot of hospitals and health systems. I'm not here to present testimony today, but I am here to assist with any questions there might be.
Thank you, and I certainly appreciate all of you being within the time constraint we've allotted for this. Committee members, we have allocated 10 minutes for questions and follow-up, so we will entertain those now if anyone has any. Senator Carroll.
Thank you, Mr. Chairman. And I don't have a lot of information about this program, but help me understand from the federal law that was passed in relation to this program, what are the allowable uses for these discounts that are given to the hospitals or to the pharmacies? Do the hospitals decide, or is it restricted, or what can it be used for?
I can speak to some of that, Senator. It depends on the type of 340B covered entity. I think there might be 15 different types of covered entities. Federal grantees typically have to reinvest that directly into the infrastructure of their site. Some of the larger, more complex covered entities would be disproportionate share hospitals, which do not have a direct requirement to use it for this or that reason. It's used in general to extend services. Some of the examples that we've used, we directly tie it to patient access. But the federal law does not require some of that direct tying to it. Now that could be changing. I know the Congress is looking at that right now for more transparency.
Okay. So I asked a couple questions of hospitals on this, and so there's no requirement that a certain percentage of the savings on the pharmaceuticals be directly passed down to the consumer. Is there any accountability for that? I would assume that was the purpose of the program to begin with, was for the consumer to lower the prices of their medications. Is that not accurate?
That is not my understanding. My understanding is the 340B program was created to allow covered entities stretch resources further to serve the patients. Now, it's very, I think another way to ask the question is, if you ask hospitals that are 340B covered entities, what would go away if you lost 340B savings? And it's very easy for hospitals to list all the services that they are funding through savings generated by that program.
Okay. So the pharmaceuticals claim that hospitals are using the funds strictly for profit. The accusations go both ways on this. And all the programs are great that you all are talking about, but I just wasn't clear on the purpose of the program. Was it specifically meant to pass discounts down on the pharmaceuticals? But apparently that's not the case, so I guess I really don't understand the pharmaceutical companies' arguments. Do you all have to provide any reporting? Do you have to be transparent on where the savings go and exactly what you're using it for?
Senator, I will tell you, we go through an annual audit at St. Clair to justify our continued participation in the program, and we report that as part of our annual reports. In the programs in which I just described to you, we do this not necessarily as a requirement, although the 340B allocation and distribution is audited both internally and externally, but we do that proactively in order to continue to influence policymakers to continue the benefits of the programs.
Okay, but is there a government entity that audits these programs where the money is being spent?
Yes, Senator. HRSA, the Health Resources and Services Administration, periodically identifies healthcare providers that participate in the 340B program for routine audits, and they are looking at a variety of things, mostly at compliance, to make sure that it's going to that only patients receive 340B purchased drugs, and also for outpatient services.
Okay, so can you all help me understand the issue that the pharmaceutical manufacturers have? Is it by law, is it really any of their business what you spend the money for, as long as it's for those purposes? It may be a loaded question, but I'm going to ask it anyway.
I can see why pharma doesn't like it, because it requires them to offer a discount. But I can assure you that covered entities are using those savings to extend resources further. And it's not a tax on the American public.
Okay.
It's a discount forced on pharma manufacturers. Savings get used to extend resources further.
Okay. One more. Yeah. And under what provisions of the law are they claiming that they can deny these discounts? Is it interpretation that they're...
Well, that's actually a question that is a very relevant one today, because there are a number of cases across the country in which they're disputing whether they can actually deny these discounts in other states. And that actually ties right back into the real purpose of this bill. This bill really has one sentence that summarizes exactly what it attempts to accomplish, and it's in subsection 2. And it really just says that a manufacturer shall not discriminate by offering a 340B price if the manufacturer offers the same drug at a 340B price in another state. It doesn't necessarily set the price. The manufacturers still have that opportunity under federal law and as part of the market. But what it does say is if that discount's going to be offered in, as Mr. Allmeter said, in Arkansas, they can't deny that discount in Kentucky. It's intended to be an equitable way of making sure that that discount across is given to all Kentucky providers.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Carroll. Senator Douglas.
Ask a question. I have a simple question.
Well, certainly.
Since Senator Carroll took one of my questions, and that was very, very smart of him, I'll stick to this one. It was mentioned that the manufacturers really do sometimes block or create barriers to small or other pharmacies in terms of utilizing 340B. Many people in the healthcare space don't have a clue what that means. And so if you would just briefly give some examples of how that's done.
It's currently what's happening with contract pharmacy is we will get notifications from pharma that upon this date, you can no longer have X many contract pharmacies. You may designate one. And if you're going to do that, you have to share a lot of data with us. So there's an incredible amount of data sharing required by hospitals. A lot of hoops you have to jump through, and it's making it difficult. And then there's some products that are just being pulled away from contract pharmacy altogether. And this tends to focus on the high dollar specialty therapy products. That's where most of it's where most of the savings and most of the costs lie within these products.
Am I, if I may, please, Mr. Chair, are we to understand that sometimes those hoops, as you've mentioned, sometimes get moved or raised or lowered or moved to the right or left?
Correct.
Okay. So it's trying to kick a field goal when someone keeps moving the field goal. Is that sort of?
That's correct.
Okay. Thank you, Mr. Chair.
Thank you. Senator Adams.
Thank you, Mr. Chairman, and thank you for your testimony today. And correct me if I have a misimpression, but it sounds to me as if your testimony today is that the 340B program is working great for hospitals, that you all are doing wonderful things with the cost savings from this program. So if that's the case, why the need for this bill?
Like, I can speak specifically for St. Clair. Our cost savings last year were a total of $5.5 million from this. In the first 6 months of this fiscal year, we've already lost $3.6 million of last year's $5 million cost savings because of the moving goal post imposed upon us by the manufacturers. And those savings are not going to be here at the current run rate for fiscal 24. We're going to have to reevaluate these services that we're subsidizing in order to try to improve the health status of those populations. It's just not sustainable without the cost savings being redirected to these safety net programs.
So based upon, may I, Mr. Chairman? So based upon that answer, have you done the forecasting of what Senate Bill 27 would result in increased savings to the institution? So if we implemented this, what would that mean for you all?
Based upon our internal analysis, Senator, it wouldn't be an increase in savings. It would be a stability of the savings that we've had previously. We're not looking to gain the system for additional cost savings. It's just what the program was intended to do. We're trying to protect those savings so that we can continue to reinvest into these safety net programs.
Yeah, and one last question really quickly. I know that this is an important financial kind of formula for rural health care. Do the urban and suburban areas also participate in 340B? So this is a Commonwealth issue?
That's correct.
Okay.
I was just going to add, similar to what Don shared, that we're in the same exact situation, and what the Senate bill would do is just restore us back to the savings that we were receiving before the restrictions that have happened over the last few years, the moving of the goalposts.
Okay, thank you.
Thank you. Last question for Senator Berg. We have about 3 minutes, Senator.
Thank you, Mr. Chairman. And this isn't actually a question. I just want to make a statement. Guys, you have to understand the fact that they are able to vaccinate 62% of their hepatitis C patients. It's going to ultimately save this Commonwealth millions of dollars, because we know the trajectory of that disease. We know how expensive treating cirrhosis and portal hypertension and hepatic cellular carcinoma becomes for each and every one of these individuals eventually. So we are actually doing a tremendous cost savings down the road by doing this. So I just want to say thank you from the Commonwealth, because this will save us millions of dollars and lives and quality of lives on top of that. Thank you.
Thank you, Senator Berg, and thank you, our presenters. Appreciate you. Again, same with the time constraints we've allotted for this. We have 2 people speaking in opposition. Ask them to come forward, please. If you would, please first identify yourself for the records, make sure the green light is on the microphones, and proceed. Again, same constraints here, 20 minutes to state your case.
All right. Good morning, everyone. Thank you for allowing us the opportunity to speak in opposition to Senate Bill 27. My name is Loris Remnick, and I'm the Director of Government Affairs, State Government Affairs for the Southern Region with the Biotechnology Innovation Organization, otherwise known as BIO. BIO represents emerging biotech companies and research institutes, as well as established manufacturers, the most innovative medicines improving patient care. We also have an affiliate right here in Kentucky. It's Kentucky Life Sciences Council. Unfortunately, the head of the council could not be here today due to illness, so you have me instead. Also in Kentucky, the bioscience industry is growing with over 16,000 jobs in the sector. I wanted to provide first a background on the 340B program and why we oppose Senate Bill 27 before my colleague over here goes into a little bit more specifics about the legislation. But I did want to be clear before we start that we are not opposed to the 340B program. Actually, in 1992, the biopharmaceutical industry was in full support and helped establish the 340B program that Congress created. And the original intent was to help uninsured and vulnerable patients access the medications that they needed. As part of the law, drug manufacturers agreed to provide significant discounts on outpatient medicines and treatments to select eligible healthcare safety net organizations, otherwise known as covered entities. These covered entities are then supposed to use the savings to help provide charity care to those who are uninsured and vulnerable patients. This was originally intended to be a small program to ensure a few safety net clinics and hospitals were not unfairly burdened with the full cost of medications that patients were unable to pay. As it relates to this bill, Senate Bill 27, pharmacies that contract with these covered entities were not included in the original 340B statute. I think that's important. However, due to later and questionable interpretations of the law, contract pharmacy arrangements in the program have grown by over 4,000%, as 340B has exploded in the second largest prescription drug program in the nation, second only to Medicare Part D. Despite this massive growth of the 340B program, evidence suggests that patients are not seeing the significant savings passed down to them in the form of financial or copay assistance. A recent study of 38,000 340B contract pharmacy claims showed that only 1.4% of patients saw portions of the discounts. 1.4%. Contract pharmacies are also a significant source of illegal diversion and duplicate discounts, as much as 66% of that, in part due to the fact that they often do not identify patients as being 340B eligible until after the prescription is dispensed. 340B is a federal program, and therefore we believe any adjustments to the program should be made at the federal level and not a patchwork of state legislation. Additionally, the Third Circuit Court of Appeals looked at requirements similar to this legislation and concluded that the 340B program does not require delivery to an unlimited number of contract pharmacies, something that's specifically called for in this legislation. There are also 2 other court cases pending in the U.S. Court of Appeals in D.C. and the Seventh Circuit on this topic. Senate Bill 27 would expand federal law beyond what Congress intended while doing nothing to benefit access to care for those in Kentucky. It would also be a mandate on manufacturers dictating how they sell and price their products. For these reasons, BIO respectfully opposes Senate Bill 27, and we urge the committee not to move this bill forward. Thank you so much for your time.
Good morning, Chairman Meredith, Vice Chair Douglas, members of the committee. Thanks for having me here to testify this morning with support for the original intentions of the 340B program, but unfortunately in opposition to Senate Bill 27. My name's Kip Snyder. I'm National Vice President of State Policy for the Pharmaceutical Research and Manufacturers of America, known as PhRMA. PhRMA represents the country's leading innovative biopharmaceutical research companies. And I want to note at the outset, as my colleague Laura did, PhRMA and its member companies strongly supported the origins and the goals of the 340B program, dating back to 1992 when the program was established by Congress. It was intended to help low-income and vulnerable patients access medications that they otherwise were not able to afford. The problem we have today is, unfortunately, the 340B program is now quite broken. It was intended, again, to be narrowly tailored, aid the underserved, but there's been a lack of oversight at the federal level that's caused it to spiral out of control. You heard the reference. It's now become the second largest federal prescription drug program, second only to Medicare Part D. And worse yet, it's actually not benefiting the patients that it was intended to serve, and it's not helping our broader healthcare system. It's really become sort of an ATM for pharmacy benefit managers and corporate pharmacy interests. And that's why PhRMA is 100% on board, on the record, as part of a coalition seeking major reforms to the 340B program, but at the federal level. It has to be done at the federal level. This is a federal program. So the essence of the legislation today, Senate Bill 27, is requiring manufacturers to ship products at 340B prices to unlimited numbers of pharmacies that have contracts with these 340B covered entities. So the so-called contract pharmacies issue, that's what this is about. So these are entities that wouldn't in and of themselves qualify for 340B pricing alone. The federal 340B statute doesn't authorize and in fact doesn't even mention the term contract pharmacies. There's a graphic in your handouts that we provided that shows you the growth of the 340B program. It looks like a hockey stick, 8,000% over since 2010. So there's just been this unbelievable explosion, and frankly, it's due to abuse of the program by some bad actors and rating the program way beyond what its original intent was. A lot of these contract pharmacies are located miles and miles and miles away from the covered entities with which they contract in different states. They're not part of the service areas for the covered entities themselves. And in fact, there's a Kentucky-specific statistic I really want to direct all the committee members to. I want to make sure you understand it's in your handout. It comes from the federal government. You heard HRSA, the Health Resources and Services Administration, which tracks and attempts to regulate all this 340B stuff, right? So you look at Kentucky 340B covered entities. There's a total of 2,690 contract pharmacies. And of that number, only 1,650 of those are even in the Commonwealth, right? Now, I realize this is a state, it's got metro areas that border Ohio and Indiana. I happen to be married to a Hoosier. But even considering that factor, you can just see plain as day that something is way out of whack with this program and the way it's encountered this explosive growth. So Senate Bill 27 also has the unintended consequence of being really a PBM or a chain pharmacy money grab. Since 2010, the number of has grown, as I referenced, and there's this vertical integration right in the supply chain. So now you have PBMs that own the vast majority of pharmacies in the United States, and they stand to make a profit from these expansive contract pharmacy arrangements. So more than half of the 340B profits that are taken out by contract pharmacies are in fact concentrated in 4 pharmacy companies: Walgreens, Walmart, CVS, and Accredo. You'll see some of that information in your packets as well. So in addition to acting as a sort of an accelerant, right, for a program that's being abused, Senate Bill 27 does nothing to guarantee savings for patients. The question came up earlier: does the law require that patients benefit and receive the savings that manufacturers provide? The answer is no, right? So the stakeholders here can do what they want with this money, and it's pretty obvious that the money is flowing out of the underserved communities, frankly, all over the place. An analysis of contract pharmacy claims for brand medicines found evidence again that a very, very small percentage, 1.4% of those claims, were actually benefiting patients. And we've seen this incredible growth in Kentucky. Only 50% of contract pharmacies are located in medically underserved areas. Now, my guess is that most of you probably have pretty good commercial health insurance, and you walk into a pharmacy and you pick up your prescription, and your insurance company pays for it. Maybe you have some cost sharing. It's quite likely that many of you have picked up prescriptions and they're actually 340B claims, and you wouldn't even know it. Right? That's what's going on here. There's these expansive networks of contract pharmacies, and this stuff is sort of being done behind the scenes, and there's insufficient accountability and transparency, and that's why you see this incredible growth. So what we have is we have a broken, out-of-control system that needs reform at the federal level, regulated by the federal government. The United States Senate, as a matter of fact, is currently investigating abuses under the 340B program. Senator Bill Cassidy, who's a physician, Louisiana, he's the ranking member of the Senate Health Committee, recently sent out letters as part of an investigation into how 340B gains are being used. And Kentucky's own Brett Guthrie, so I know once served in these halls, is currently chairman of the House Energy and Commerce Health Subcommittee. That subcommittee's been working to pursue bipartisan reforms such as transparency to try to address this problem. So another point, the 340B program is also mired in a series of lawsuits. Some of these involve interpretation under the federal 340B statute. Others are challenges to state laws that are highly, highly similar to the provisions that are in Senate Bill 27. So summing it all up, a vote for this bill really is a vote to place mandates on private companies to essentially force them to ship at 340B pricing to contract pharmacies without regard to any terms and conditions that they want to try to put on to put in place accountability and to prevent diversion. And it's expanding a broken federal program that's under Senate investigation for abuse, and it's subject to just really a firestorm of lawsuits right now. So for that, we would urge a no vote, and that concludes my testimony, and happy to answer any questions you have.
Thank you. Appreciate the testimony. Appreciate you again staying with the time constraints. And since we are running just a little bit ahead of schedule, what we'll do is allot 10 minutes for questions of these two individuals, and I'll allow 2 minutes at the very end for each party to have a summation, if that would be appropriate. So with that, Senator Frankie Fromeyer, I believe you have a question, comment?
Yes, thank you so much for bringing this to our attention. And when I do look at the second slide that you provided and the hockey stick of growth, it does make me question or try to better understand health versus health care. And if it's grown so dramatically, does this also express that there has been that many more prescriptions prescribed to those that might need these various drugs? And can you help explain the improvement on Kentucky's health from 2010 to the present with this hockey stick of perhaps use and access to these drugs by the underserved or the unable to pay for themselves? I just want to better understand how much healthier Kentucky is.
Yeah. Well, thanks for the question, Senator. I think that for the most part, what we've seen is a sort of seismic conversion of prescription volume that previously was not within the 340B program that has been converted over to 340B claims, again, principally through this expansion of contract pharmacies. Has it helped patients? I'm not going to say it hasn't helped patients. I know that the hospitals are trying to do the right thing to a large extent, but if you look at what's going on here, it's pretty clear that the bottom line is sort of trumping charity care and the underserved. I don't think if you go in and look at statistics on helping these vulnerable communities and helping with charity care that you're going to see the same hockey stick like 8,000% growth. That's not what's going on here.
Senator Berg.
Thank you, Mr. Chairman. There's been a lot of change in healthcare as far as coverage for pharmaceuticals, because historically we didn't cover pharmaceuticals, and now many people have plans that do. And it seems to me that as part of that, something has popped up in the middle of all this called pharmacy benefit managers. With these pharmacy benefit managers, how much are they responsible for the growth in 340B programs, seeing it to be in their personal financial interest, as opposed to the growth in 340B programs from things like University of Kentucky or other healthcare facilities that actually serve underserved populations and need that revenue, not necessarily to go directly to the patient for their medication, but to support the environment for that patient. I mean, it seems to me we had a program that was working until the PBMs came in there and said, no, we want this money. We want this money. We are for profit. We are taking this money out of the healthcare system and keeping it for ourselves. So it seems to me the problem is not actually the 340B program. The problem is our pharmacy benefit managers who are vertically integrated, taking advantage of a government program that's supposed to support the underserved. And we, unfortunately, sir and ma'am, as a result of the inaction of the federal Congress, are having to step in and protect those programs in this state that are vital to healthcare delivery in this state. And whether it's a perfect solution, which obviously it is not, we have no other choice at this point. So I would suggest that pharma needs to go to Congress and say, get rid of the PBMs, control them, and fix this now before the entire program collapses.
Senator Berg, you're spot on. I could talk for a long time about PBMs. The short answer to your question is we absolutely are doing as an industry exactly what you've just described. We're very, very public about this. We are clamoring for reforms at the federal level. They're going to take some time. But you've got 3 PBMs, right? These PBMs, they started off as claims administrators, in the 1980s, and they've morphed into these mega corporations, vertically integrated and combined on the top end with insurance companies and owning, as I referenced, the vast majority of pharmacies in the United States. 3 of these entities control 80% of prescriptions in the United States, right? And so do they stand to make a profit when this network of contract pharmacies, most of which they own, expands? You bet they do, right? So a vote for this bill is going to provide a payola and a windfall to the PBMs.
Thank you. I have 2 other committee members who wish to question. We've got about 5 minutes left in this segment, so please be aware of that. Senator Douglas.
Thank you, Mr. Chairman. More of a statement than a question, so I'll make it fast. You cited some court cases, or at least one in particular, that said that, in fact, the words were "does not require," the contract entities, but it doesn't exclude them. One of the things that anytime I have an opportunity, I make known is that there's no doubt that more affordable pharmacotherapeutic products will somewhat help our healthcare outcomes. But again, I'm going to continue to toot the horn that is not the major determinant of our healthcare outcomes. It is a supplement to our healthcare outcomes, and I at least what I've seen over the years is the major determinant of our healthcare outcomes is whether or not we have patient buy-in and patient participation in the improvement in their health care. I think this is a separate, because someone else earlier asked whether or not we've seen improvement in our health care here in the Commonwealth. And I want to make sure that I point out that we'll see improvement in our health care outcomes here in the Commonwealth when the people of the Commonwealth participate more in their health care outcomes. It's not necessarily because they have more access to medications or because they have more access to our hospitals. A lot of that access is there. Thank you, Mr. Chair.
Thank you. With there being no further questions, comments, I'll allow each party to have 2 minutes to provide a summation. Since you folks are at the table, would you like to go first?
Sure. Would you like to say anything first, Laura?
Sure. Yeah, I just wanted to thank the committee so much for their time for hearing us out. And, I think some of the concerns that have been raised about PBMs, especially in vertical integration, I think, this legislation will only exacerbate some of the issues that we're already seeing by forcing manufacturers to give the unlimited discounts. So that'll actually exacerbate the profits by the PBMs. And I have this statistic here that I thought was interesting in one of our handouts that I'm happy to get to the committee as well. It says a contract pharmacy's average gross profit margin on a 340B medicine dispensed at a contract pharmacy is 72% compared to 22% when dispensed by an independent pharmacy. So this is definitely, like my colleague has said, a kind of a cash grab by the PBMs. So again, I just would like to thank you all for your time and, would reiterate that we are absolutely not opposed to the 340B program. We helped create it at the federal level. We just think that any reforms or adjustments should happen at the federal level, and that, this kind of legislation is not the way to go about it. So thank you so much. Appreciate it. And if you have any further questions, happy to answer.
Thank you. Appreciate your testimony and summation. Does anyone want to speak on behalf of the first group?
Could I say one more thing on behalf?
Briefly, yes.
Yeah, I just at the end of the day, this issue is about exploiting fuzzy federal definitions, and in a program where there's poor oversight. And I know we're up here opposing this bill, but I want to say, if it's really about helping patients and not padding corporate bottom lines, there are other solutions. One of those solutions we've been very publicly in support of in states across the country is what we call the share the savings model. And I believe there's legislation that you know something about, Mr. Chairman, in this legislature, in this Commonwealth this year. That's something that is a proven solution that requires discounts and rebates to be passed on to patients now. 3 states have already enacted it. It's working, so we would tell you to look
Thank you.
there.
Appreciate that. Gentlemen, again, 2 minutes, please.
Yes, Mr. Chairman. Yes. Thank you, Mr. Chairman, Senators. We appreciate your opportunity and your leadership on Senate Bill 27. I'll keep my comments very brief. I think it's important to read one particular sentence again about this bill, because there was a lot of testimony that offered a number of distractions as to other aspects of the 340B program, which I think our friends on the opposite side correctly said need to be addressed in Congress. But what this bill does is really summarized in one sentence. A manufacturer shall not discriminate or cause others to discriminate against a 340B covered entity by refusing or withholding 340B pricing for a covered drug if the manufacturer offers the same drug at a 340B price at another state. And I think of it like this. Imagine going into a restaurant, asking for the menu, getting the menu and seeing the prices. Then the server asking, where are you from? Are you from Kentucky? You say yes, and the server says, oh, you get this menu, and the prices are all 33% higher. That's all this bill does. It wants to make sure that the menu that's offered in other states is offered to Kentucky providers. That's the focus of this bill. As Mr. Almeida said earlier, there's nothing that can be done in any state legislature that will alter the 340B program. It is a program that's been in existence for a very long period of time. But what is important is that if the rate sheet, the pricing sheet that's offered in other states should be offered in Kentucky. This protects Kentucky providers and the drugs that they purchase.
Thank you, Mr. Chairman.
25 seconds.
I wanted to comment on an issue that was brought up in the last testimony around PBMs and vertical integration. I think it's important to note that there are 29 states with laws on the books that have addressed PBM reform with the 340B program. And I highly encourage that. And Kentucky is one of them. Senate Bill 50 from Senator Wise that came out years ago is a progressive bill that has done tremendous efforts with PBM reform in this state with Medicaid. And taking the same action with PBMs in general, looking at the 340B program would be a great next step.
Thank you. Appreciate that. We do have one final comment, question. Senator Elkins?
I really, I'm just trying to narrow, or I guess get this square in my mind. So you're telling me that all we're asking for is a favored nation clause, basically, and we're not looking to expand this 340B any more than it is, no matter if you have issues with 340B or not, that this isn't the place for that. We're just looking for a favored nation clause. Is that the way I interpret this bill? Is that correct?
That's pretty close, Your Honor. I'm sorry, I'm used to being in a court. Pretty close, Senator.
All right.
Thank you.
Pretty close meaning, where am I missing?
Well, just most favored nation status is a bit of an obligation with respect to pricing, and this is really an anti-discrimination bill. It's basically saying that you can't really treat Kentucky providers different than you would other providers in other states, and it's got some enforceability through the Attorney General if that were to happen.
And we're talking about pricing only, correct?
Yes, and ultimately the manufacturers get to set the prices according to whatever rules that the federal government says. So this actually has no impact on pricing itself. It's just the availability of pricing that would be offered in other states must be offered in Kentucky.
That's how I thought I understood it. Thank you for your testimony, both of you. Thank you, Mr. Chair, for the additional time. I appreciate that.
Most welcome, sir. And I will concur. Appreciate everyone's testimony this morning. I appreciate the attendance of our committee members. We probably have this on our agenda for our next meeting, which will be February 7th, again at 9 o'clock a.m. in this room. If there's no further business coming before this group, we stand adjourned. Thanks, everyone, for attending.